Okay, our last speaker in this session is Dr. Melissa Lopez Varon. Melissa is a cancer epidemiologist and program director at MD Anderson. She leads the implementation of comprehensive cervical cancer prevention and control initiatives for underserved communities and populations in the U.S.-Mexico border region in South Texas, in Mozambique, and Latin America. Dr. Varon serves as the co-leader of the Project ECHO Extension for Community Healthcare Outcomes Super Hub for Oncology at MD Anderson, and she collaborates with clinicians and clinical leadership to develop and implement telementoring and capacity building programs that address cervical cancer in resource-limited settings.
Thank you, everybody. Thank you so much, Maria, and everybody for the invitation. We are very honored to be here and present the work of many. So as you heard, I work at MD Anderson here across the street, but I'm also from Colombia. So welcome, everybody from Latin America. So cervical cancer, for those of you who don't live in the cervical cancer world, is the poster child of disparities in cancer. So you can see here the darker blues, these are incidence rates, specifically places for low resource settings. So 80% of cervical cancer occurs in low resource settings, including areas of our own country here in the United States. And that's in part due, for example, due to access issues. We were talking about access this morning. In the Texas state that you see here, also darker blues, insurance prevalence is about uninsured is about 18% comparing to the rest of the country, which is about 8% now. And so we see that over and over again. The other thing I wanted to highlight in this image here is that in Latin America, you have a gradient of colors. And this could be a bad thing, but it could also be an opportunity for us to learn from each other. And I think that's what we're trying to leverage with the Project ECHO model here. So we know that HPV causes cervical cancer. We have a vaccine that prevents cervical cancer infection or HPV infection. We have a way to screen women against cervical cancer. We have treatment, early detection. So in 2018, the world got together against cervical cancer. And the WHO leader, Dr. Tedros, released a call for action to say, let's get together to eliminate cervical cancer as a public health problem. And then in 2020, it was adopted by the World Health Assembly that we have this initiative, this global strategy to eliminate cervical cancer with 3 pillars with their own targets. So we have the first pillar, which is vaccination, where we have 90% of girls fully vaccinated by the age of 15 years. We also have a pillar for screening with the target of 70% of women screened at least one in their lifetime or by 45 years of age with a high-performance test, meaning HPV sampling. And then we have this third pillar for treatment, where we aim at treating 90% of women either identified with pre-invasive disease or with cervical cancer. And I highlight treatment here because we think that's one of the weakest pillars. But the other thing is just like looking at this, what could go wrong, right? Many, many things. And one of the ones that I want to highlight is that not even the same groups of people work together for this. We have silos. We have your immunization silos, and then you have your cancer silos, and they don't necessarily talk to each other or even know each other. And then that's one of the many things that we can identify here. So we have been using Project ECHO, which stands for Extension for Community Healthcare Outcomes. It was not developed at MD Anderson. It's actually a long-standing intervention for hepatitis C. It's evidence-based, and it has this premise of demonopolizing knowledge, meaning we want to share knowledge together through a network of learning. And there are many Project ECHOs worldwide, thousands of them. At MD Anderson, we have about 30 different programs from prevention to treatment, palliative care. But the goal is really to serve patients programs in low resource settings where we don't have an academic center necessarily to advance best practices that are closer to home. And then in this way, using telementoring, we promote interprofessional relationships to make an impact. And so we thought this could be a good way for us to adopt a program that could serve our region in Latin America to reach the elimination strategy. So you could see here a picture of our first ELA session. ELA stands for Elimination of Cervical Cancer in Latin America. And you can also see here that it is a trilateral collaboration between MD Anderson, the Pan American Health Organization, which is a branch of the World Health Organization, and then the National Cancer Institute here in the US. And then we work together to reach our community in Latin America to make sure that we are helping them in supporting them in, for example, creating a cervical cancer elimination plan, or even embed that into their cancer control plan nationally. So our goal really is to disseminate impactful strategies for elimination in the region, to leverage on that diversity of resources to learn from each other. Our audiences are mainly ministries of health personnel, but also clinicians and academicians. We launched the program in May 2020 during the pandemic. And then we conduct these sessions in Spanish. We are currently in our third iteration or third year of implementation of the program. Some of these are faculty that have joined since the year one and continue to join us for many years. And now we have elevated them to the point of faculty. So we have Dr. Alejandra Armengón Alonso from Mexico, Jane Montealegre and Mila from MD Anderson, Dr. Natalia Katz and Dr. Alejandra Picconi from Argentina. And they help us in sustaining this knowledge and then continuing to disseminate through the region. We base our sessions in the 3 pillars that I shared with you before. And here, just some ELA numbers. You can see that we have participation throughout the region. We have more than 500 registered participants. We have held 32 different sessions with an average of about 67 participants. About half of the participants are doctors and working at the Ministry of Health level. And then here, I just wanted to just share our attendance rates for the first, second, and third year. And then you can see here, just highlight blue and orange, our attendance in the first sessions was very high, and then it went down, and we feel that it was like kind of like a misalignment of goals and understanding what we were doing. And then we feel like this year, this third iteration, we're doing so much better because we're sustaining our attendance, meaning we were well aligned with what we intended to do, what we aimed to do, what they perceived we wanted to do, and really making sure that we are reaching the right audience. We have evaluates qualitatively our program, and quantitatively. So in terms of our outcomes, we have about 66% of them participants that they had a need to strengthen capacity. 80% of them reported that they wanted to learn more about vaccination. So we tailored that in the following years. And then most of them highlight the importance of learning among their own network. So yes, great, MD Anderson, fantastic, but we really want to learn from the partners in Argentina and Chile and Colombia. And then we did 2 focus groups, and this was highlighted even more, where they say, I learned how different countries are addressing cervical cancer elimination. And in turn, this helped me think strategically about how to do this within my own country. But we don't stay there. PAHO is really taking the lead in making sure that they have a plan for cervical cancer elimination. So we are holding elimination workshops. We held 3 to date. We are going to hold 1 more for the Caribbean region, where we get people together, we sit down and we think about, okay, how can we create an elimination plan that works for my country that will be attainable in the near future, and then we support them through the project echo sessions. And then here, just highlighting some of our publications and just concluding that we were a little hesitant about adapting the model for health policy, public health settings, but it was really good. We just had to adjust. We had a few challenges, but we are very happy to see our community growing. And then we have seen that it increased participant knowledge and satisfaction. We want to continue to evaluate our programs, disseminate our experiences. And if anybody's interested in participating, attending, observing any of our Project Echo sessions, please feel free to reach out to us. And thank you all so much for your attention.